Okay, did anything come up now? Okay. Okay, I think it's recording now. Okay.
Perfect. So my name's Kornelia. I'm one of the 5th years at this university, and my colleague over here is.
Oh, hi. My name is Dorthe, and I'm also in 5th year together with Kornelia, and I am happy to present together with Kornelia today on differential diagnosis of dyspnea.
Okay, so I'm just going to quickly go through a few things that we'll be covering today. So we're going to obviously give you the definition of dyspnea. We're going to give you some numbers. We're mainly going to focus on things that you are most likely to see
What? Okay, wait.
The things that you are most likely to see in a clinical environment. We're going to tell you about the mechanism behind dyspnea, but don't worry, not too much. Just the differential according to the organ system and certain onsets, if it's acute, subacute, chronic. Some special considerations. And what we should be focusing on when we are presented with a patient with dyspnea. Then we're going to go into kind of where we start, for example, with physical examination, lab diagnostic, and then we're going to end off with some cases, which we can't wait for.
And we would appreciate if you would participate in this lecture, because I know that a few of you are only in your 3rd year and you haven't done pathology or pathophysiology, but this kind of like clinical thinking is something that you develop over years, and it's not something that they give you a paper after 6 years and then you're a diagnostic machine. Like, this kind of clinical thinking is something that you have to develop over time, and that we sadly aren't provided with enough in this uni. So that's why MIMSA is doing a great job with providing these lectures for you. So don't be afraid to kind of spill your thought and just engage in the thought process, because we all have to begin somewhere, and we're all like, even though we're in 5th year, we're not some magical creatures that can do these things. Like, this is great for us as well to kind of develop on how we think in our approach to clinical cases.
Okay, so dyspnea. So it's defined as a subjective sensation of not getting enough air. So patient often tells you that they are out of breath, they have breath, but in situations where a healthy person is not out of breath. So can anyone tell me what like the normal respiratory frequency is? Any number?
Like 12
15.
to 12 to 20 or something.
Yeah.
Yeah.
So that's like the normal range.
Exactly. Perfect. Okay, so the differentials that you should be then thinking about when someone has shortness of breath would be tachypnea, which is, we would say, a frequency of more than how much? Does anyone know?
25 and above.
So above 20, we would say already they're tachypnic.
Okay, fine.
Hello, Jessica.
Hello.
Perfect. So yeah, above the normal range, they're already, so they have a more rapid breathing. Orthopnea, does anyone know what that is?
I'm not answering now.
Okay, so it's basically the sensation. Sorry.
Hi.
Okay. I was gonna say, like, if you're standing up, then it's better, like autopnea, so straight breathing, basically. So like if you're standing up, there's better circular, like, breathing for you.
Yeah. So basically, you have dyspnea when you're laying down. That is orthopnea.
Yeah, exactly. So when you're laying down. So for example, in patients with heart failure, because of like build-up of ascites and stuff like that, they're more likely to have this. And then we have nocturnal dyspnea, so difficulties breathing during the night. Okay, so here are some numbers for you. So, so 2 to 4% of all GP consultations are due to dyspnea. So now we're going to give you some numbers of like common things that, for example, if you were a GP consultant, that you would see. So in acute, you could have acute bronchitis, which is 25% of the time. Asthma 9%, upper respiratory tract infection 8%, and cardiac failure 10%. And in children, so if you have dyspnea and fever during, for example, influenza season, it's more likely to be a respiratory syncytial virus. And then in chronic dyspnea, the complication is usually a part of a more complex clinical picture, and usually not the main cause of the consultation. So 90% of the cases attributed to diseases in the airway, lung parenchyma, or the circulatory system. And we know that the airway and the lung parenchyma account for 70% of the reason for dyspnea.
And now I just want to go briefly over some pathophysiological mechanisms which can cause dyspnea. So there are multiple ways that you can experience dyspnea by. So first you have mechanoreceptors in the airways, lung parenchyma, chest wall, and peripheral musculature, which can induce dyspnea. And for example, in peripheral muscles, like, have you heard about this, what's it called? When you're like going to train, your respiratory frequency and your heart rate goes up because of this kind of anticipation that you're starting to move, and not necessarily because you have an actual need for more oxygen, but it's just like the body's way of kind of safeguarding towards this future increased demand. And then you have chemoreceptors in peripheral arteries and CNS, for example, like the carotid body, in the medulla oblongata, where you sense the pH of the cerebrospinal fluid, and in the aortic arch. Then you have the respiratory drive in response to hypercapnia, hypoxia, VQ mismatch, or shunting, which will increase the respiratory frequency. Then you have diseases of lungs and airways, which can be classified into obstructive, restrictive, and combined, and VQ mismatch. And I just want to ask if you can give me some examples of restrictive disease. Anyone?
Sorry, what's the question again?
Fibrosis?
Yeah, fibrosis. And then you have obstructive disease. Any examples?
COPD?
Oh, COPD, asthma.
Yeah. And then you have combined restrictive obstructive diseases, which are, for example, again, COPD, which can also be of that category. And then you have circulatory disturbances such as heart disease, lung embolism, and vasculitis, respiratory depression from CNS disease and drugs, or for example, trauma. If you have head trauma, you can see a decreased respiratory frequency as well. Psychosomatic, for example, in anxiety and depression, and then anemia. And just like from this brief overview, do you have any thoughts of which of these can be the most common cause of acute dyspnea?
Psychosomatic, maybe?
Good suggestion, but it's anyone else?
Heart disease?
No, but it's also very high on the list.
Drugs?
The most common is
Hypoxia?
Yeah. So basically, the most common mechanism, as you said, is input from the chemoreceptors that tells about hypoxia, hypercapnia, and, for example, acidosis. And For example, hypoxemia can be due to COPD, pneumonia, pulmonary embolism, hypercapnia from obstructive disease, neuromuscular, acidemia, which can be from metabolic acidosis, like ketoacidosis and lactoacidosis, and then you have poor delivery of O2 in, for example, anemia and low output heart failure.
Okay, so this is now the differentials according to the different organ systems that can be affected and that can lead to dyspnea. So this is where we would start off with straight away with when you're thinking about when someone has dyspnea. So all of these different systems that could be affected. And as you can see, we've obviously highlighted the ones that are most likely to occur. So for example, in lung and airways, it could be inflammation such as asthma, COPD. So with asthma, basically we could, so when someone has asthma, right, you're also looking for example, like wheezing, chest tightness, pruritus, some kind of hives. So any type of like allergic reaction, and if they are much younger. With COPD, so it could be like a chronic smoker with a decreased lung function, and it could be some kind of long-term coughing. Then interstitial lung disease can also be a reason. Then you could have infections such as a pneumonia, acute bronchitis. With vessels, it could be pulmonary hypertension, which will lead to edema, and the pulmonary edema will lead to the difficulty in breathing. And then you have pulmonary embolism. So with pulmonary embolism, we're thinking of depending, for example, if it's some kind of hospitalized person, if it's a younger woman that's on birth control, which is high risk for pulmonary embolism, and then also malignancies. So with the cardiac, we have, for example, a heart failure, and then we have arrhythmias, which are very common. Then we have neuromuscular, so kyphoscoliosis, or other chest wall deformities. And then with the metabolics, you have anemia and metabolic acidosis. So as Dorthe was saying, it would the acidosis, so the increase in H+ ions will stimulate the chemoreceptors and lead to the dyspnea. And others could be, for example, psychologic, such as anxiety, which is quite common, and depression, sleep apnea. And then there's drugs such as NSAIDs, cortisone, beta blockers, and anti-epileptics.
I just want to shoot in like just a few remarks. Under lung, like on malignancy, it's important to remember that the cancer itself rarely causes the dyspnea, but like the effects of the malignancy on the lungs will cause the dyspnea. And for example, pleural effusion because of the irritation from the pleura, or any obstruction, inflammatory reaction surrounding edema, like those kind of things. But the tumor itself rarely causes dyspnea, and when it does, the cancer has probably come a long way. And with regards to the drugs that can cause dyspnea, there is one that you absolutely have to remember, even for pharmacology. That is the amiodarone lung. Like amiodarone is a antiarrhythmic, and it has a side effect of causing lung fibrosis, like an interstitial lung disease, and that can over time cause dyspnea. So just be aware of amiodarone for interstitial lung disease.
Yeah, that's a good point. So if you see, for example, with a patient and you look at their the drugs that they're taking, and if they are taking amiodarone and they have a new symptom of dyspnea or some kind of lung problems, then it's most likely to be this.
Okay, and then you have like, okay, because the previous slide was great in terms of kind of a overview, but like it is unrealistic to expect someone to remember all of that, like just at a glance. So then you have at least like these 6 P's, which are pneumonia, pulmonary bronchial constriction, which is asthma, COPD, possible foreign body, pulmonary embolism, pneumothorax, and pump failure, which is heart failure. And these P's are also the ones that are most likely to kill the patient as well, because like our main goal is to prevent the patient from dying. So if you can remember these, that's great, and it will actually get you a long way, because these are also the main causes of dyspnea. And then you can also categorize it according to onset, like acute, subacute, and chronic. Like acute dyspnea is anything from a few seconds till a day, 2 days. And you always have to ask about when did it start and how rapidly did it start, because an airway infection can develop over 2-3 days, but it would be classified as an acute dyspnea. And then you have exacerbation of asthma, pulmonary embolism, and when it comes to a pulmonary embolism, and if you are suspecting that in a patient, you should always ask about previous thromboembolic events and those kind of things in the family history. And pulmonary embolism is also more common in, as Kornelia said, people who have recently, for example, traveled, been immobilized, infections such as like sepsis is also a prothrombotic condition. Then you have myocardial infarction, and with myocardial infarction, you will also have chest pain. And for example, when you have a dyspnea, if you're following me, dyspnea associated with chest pain, and this chest pain can either follow the respiratory cycle, that you have more chest pain upon, for example, inspiration, which points you in the direction of, for example, a pneumonia or a chest wall problem. But if the chest pain is not associated with the respiratory cycle, then you can probably think in direction of a myocardial infarction. Acute cardiac failure, acute pulmonary edema, which can also be a complication of cardiac failure, atrial fibrillation and paroxysmal tachycardia, foreign body, and hyperventilation, which can be seen in anxiety. And hyperventilation, which is like you have something that's called Kussmaul breathing, which is a deep and rapid respiratory pattern in response to acidosis. So just keep that in mind. And then you have subacute, which is infection asthma. As I said, like those can range over from 1 day to a few days. And then you have the chronic causes of dyspnea, which are COPD and asthma, and these two have pretty similar manifestations, but you would see COPD more in the older population, and then you have asthma, which is more common in the younger population. Then you have cardiac failure with its associated complications and manifestations such as bilateral limb edema, anemia, interstitial lung disease, and malignancy. But these are just overviews and things that you shouldn't have to memorize, but the things that you kind of acquire over time. So don't panic when you see these things, but it's just kind of for you to look at it later.
Okay, so some considerations when mapping out your differential for a patient with dyspnea. So based on who comes in, for example, if you have a child that comes in with dyspnea, it's more likely to be, for example, an infection or asthma. With young adults or middle-aged patients, it could be a psychological or also asthma. With elderly, it's more likely to be cardiac failure or COPD. And how like we've spoken about before, so in pregnancy, if someone's been immobilized for long periods of time, for example, hospitalized for long periods of time, yeah, post-operative, then they have a higher risk of pulmonary embolism. So that's when you would suspect a pulmonary embolism. So this is, I think this is actually very good, because obviously when someone comes in, you can straight away then think, because you with a child, you're not going to straight away go for PE or COPD. You're going to think of these before anything else. So that already kind of helps you rule out other things that could be going on.
And especially in children, is if they come in dyspneic and, for example, with a fever, then you would think more in terms of an infection. But if they have an acute dyspnea and they're very kind of agitated and they have stridor or wheezing, then you would think of, for example, asthma, foreign bodies, like these kind of things. And just the age of the patient, like the first look of the patient, actually tells you a lot.
Yeah, that's true.
And I just want to say about anxiety, which we mentioned previously as a potential cause of dyspnea. Anxiety is always a diagnosis of exclusion. Like that is, you conclude with anxiety when you have ruled out any other organic cause of dyspnea. And for PE, you can just take a note. I'm not going to explain it because I personally don't know it myself, but you have something that's called Wells score, WELL score, and that is a score that stratifies the risk factor for pulmonary embolism, and that is a widely used scoring system for kind of looking at high-risk patients for PE. So just take note of that one. Do you want to fire away, Kornelia?
Okay, so basically a patient comes into your office with dyspnea. What do we do now? So first thing we think about is you have to do the history. So we're going to talk about the key aspects of history taking. So with the general rule, so this mainly applies to pain, but it's always good to remember as well. So it's OPQRST. See what they did there. Okay, so onset is what time? So like we were saying before, acute, subacute, chronic, you can also think back to that as well. What were they doing? What were they doing at the time that the dyspnea occurred? How fast did the dyspnea develop? Was it within days? Was it within a couple of months? How long has this dyspnea been going on? So provocation. So any triggers, anything that triggered the dyspnea. For example, with asthmatics, is there anything that led to an exacerbation of their asthma? Then we have the quality. So how is the dyspnea described by the patient? And what point in the respiratory cycle? So is it during inspiration or expiration, which will tell you a lot about whether it's obstructive or restrictive. Exactly. And then think about, so if it's constant, so if they constantly have the dyspnea, if it's intermittent, or if it's nocturnal. So with, for example, heart failure, they have difficulties breathing during the night, and which wakes them up. So this is something that they could be describing to you, and you might lean towards that. Then,
sorry, can I just say two things?
Yep.
With the nocturnal dyspnea in heart failure, like asking patients, oh, do you have nocturnal dyspnea? That usually they won't understand you, but you can actually ask them how many pillows they need during the night, because that is very kind of layman language. And also, just a side note on asthma, asthmatic patients usually have more dyspnea right in the morning, like when they wake up. You can Google the pathophysiology for it, but asthmatics have worse symptoms in the morning. So just a small little note there.
you have radiation, but here we say it applies more to pain. And then severity. So is it during exertion? And what type of exertion? Is it moderate exertion or is it more at rest? So for example, this can tell you a lot about an MI and what type of heart problems they can be having. What type of angina is the chest pain during the rest or when they are doing something, or is it all the time now? And the time, so how long has it been going on? So is it acute or chronic? So how long has their shortness of breath been going on? So other things that we should be speaking to our patients about or asking them about is previous history. So anything similar that you've seen in their history. For example, if we know that they have asthma, or if they have some kind of a coronary artery disease, or if they have atherosclerosis, and that's already in their history. Then we have smoking history. We would think about, for example, COPD, maybe any professional exposure, and then a family history of allergies with asthma, for example, lung and cardiac disease. So we would also be looking at everything else that they've said to us before, which is very, very important. So we shouldn't just see the patient as at the point where they come in. We should also look back at what else we know about them.
And okay, so we have gone pretty rapidly over history, but is there anything else you would ask a patient that comes in with dyspnea about? Because we're not done with the history. You're never done with the history. So do you have any suggestions to other things that we should ask about?
So you think we've covered everything?
Most likely not, but I can't think of it.
Okay, so no, we're not done.
Sorry. Like I was saying, we specifically have to, so for example, past medical histories, right? So specifically asked about, so any past cardiac problems that they have, so any ischemic heart diseases, heart failure, or any structural heart disease. So with asthma, so if you know that the patient has asthma, so ask whether they have been admitted to hospital before with their asthma, if they've been admitted to ITU, if they ICU, sorry. And the frequency of asthma attacks. So if they've had asthma attacks before in the future, in the future, that would have been great.
Oh wait, can I ask a question? I don't know, I'm being dumb. Maybe you guys already mentioned it. Aren't you supposed to see if the person's coughing? I don't
Guys,
know.
on the next slide.
Oh, okay, because I was like, wait, these people are mentioning all these intense things. What about the fact that they're coughing? Okay,
No.
that's there then.
Yeah,
because
it's
you
in the
guys
next
asked,
slide.
right? Like, what else to notice? So I'm like, okay, the first thing I would notice is if the dude is coughing, you know.
Of course. No, that's in the next slide.
Okay, good. So, okay, I'm not dumb. Okay, that's great.
You just spoiled it. No.
Oh, I'm so sorry. I'm so sorry, guys. I'm so sorry. Okay.
And again, with the COPD, we'd also ask about like frequency exacerbation, admission to hospitals, if they've been admitted before, if they use a nebulizer, or if they use any medication. And again, with PE and DVT, we've already mentioned all of these kind of things.
And just when you think you're done, you are not done. As Jessica mentioned,
Sorry, guys.
It's very important to always see the patient as a whole. So you should ask about the accompanying symptoms of their dyspnea, because you should, very rarely a patient comes in with isolated dyspnea, maybe in an anxiety attack, but even then they will say that, oh, I have tightness in my chest, or I have chest pain, and those kind of things. So ask about if they have any cough, whether the cough is dry or productive, like how long it has lasted, if there has been any variations in the quality of the cough. If they have productive cough, you would ask about the expectorate that is coming up. And if the patient tells you that they're having like a blood-colored brown expectorate, what would you immediately, like, where would your thoughts take you to? Just as kind of a side question.
Esophageal varices.
For example. Anything else?
Some kind of ulcers.
Maybe, but now we are very like in the GI. Of course, like the GI tract can be a source of coughing up blood, but what if we go back to like the respiratory tract? What can
Foreign
be
obstruction?
Yes.
Foreign body obstruction.
Some type of tumor, perhaps?
Yeah.
Yeah.
Yep. Cancer and, for example, an old pulmonary embolism, which led to like a lung infarction, and then you're coughing up blood. So, excellent, great. And then you should also have additional symptoms such as if they have had a fever, if there's a general feeling of illness, if there is a decreased appetite or weight loss, and a decreased appetite and involuntary weight loss again points you towards a malignancy. If they have night sweats, chest pain, tachypnea, palpitations, if they have had a syncope, and syncope, chest pain, and dyspnea can actually point you in the direction of a pulmonary embolism. Again, it sounds like everything can be a pulmonary embolism. And if you think that, you're absolutely right. That is confusing. Any edemas, rash, joint pain, allergies, and if they have had any new medications recently. For example, if a young female tells you that she recently started combined oral contraceptives, then you would be like, oh, pulmonary embolism again. This is just a lecture on pulmonary embolism. And it's all very important to always consider the patient, because taking history, especially kind of as a young doctor and students like ourselves, it very frequently feels like we're doing an interrogation, but it's good to just ask open questions like, how are you feeling today? Can you describe your previous symptoms for me? Can you describe the change? Because then you're not asking a leading question, but you're allowing them to tell you more, and usually you'll actually get more information from asking wider questions, especially when you're taking a thorough history.
Okay, so we've done the history. The next thing that we should focus on is the physical examinations. So first of all, we look at the patient as a whole. So we would look at their general appearance. So are the accessory muscles being used? The color of the patient, are they blue in color? Is the patient able to speak, or is the dyspnea so severe that they are unable to say anything to you or communicate with you? And any retractions during a respiration, so especially in small children with pneumonia, you should think about that as well. So with ORL examinations, so you should examine the nasal polyps. So for example, as this can also give a sensation of dyspnea. So with the vital signs, you can have, for example, tachypnea. Then look at the heart rate and the saturation with the oximetry. Then look at the chest. So listen to the chest, if there's any wheezing, rales, if there is any diminished heart sounds. And you should also consider if there is hyperinflation of the chest, which, for example, with emphysema, they could have a barrel chest, and determine if the chest movement is symmetrical. And then you should do a percussion, and you should always compare both sides. And then you should see, for example, if it's unilateral, bilateral dullness, or if there's some kind of hyperresonance. So then think about the cardiac examination. So if there is there any jugular venous distension present? Is there a murmur present on auscultation? And is there any abnormal heart sounds? So with the extremities, we would focus on, for example, peripheral edema. We could focus on orbital edema with, for example, asthma. Is there any cyanosis, and where is the cyanosis present? Is it in the extremities? Is it more centrally? Then we are looking for the clubbing of the fingers, which could be related to chronic hypoxia, which could be with some kind of heart defects, and with lung diseases. Then we could also do palpation. So we would palpate the lymph nodes and abdomen. Just one second. So why do you think it's important to palpate the abdomen? And in which group of patients do you think we would have to do this in?
Like in the setting of dyspnea.
Yeah.
So like why it's important to actually palpate the abdomen.
We don't mean generally why we are like palpating the abdomen.
But like in this setting.
Because of ascites maybe.
Yeah. So basically if you have cardiac failure that has come a long way, you can see hepatomegaly and ascites in that case, if it's a very far along cardiac failure. And I actually made this slide. So like, of course, you cannot cover physical examination in one slide, and that is not the point of this. But I just wrote down these things because these are the things that for myself and a lot of my fellow students tend to forget when doing a physical exam. Like, I cannot count the amount of times that I have done a physical exam on someone with some cardiac or potentially lung issue, and then forgotten to look on whether they have cyanosis or jugular venous distension. So these are kind of just the things that are easily neglected, but equally as important as just a common auscultation. So just keep that in mind. And then you have diagnostic tests. I'm not gonna go over all of them. I'm just gonna give a few remarks, and I actually want to start on the right side of the slide. So you should always do an ECG, always. If there's anything that is pointing towards like chest pain, dyspnea, if there is a loss of consciousness, always do an ECG because it is cheap, easy, and available. And an ECG can actually give you a lot of information just by simply doing that. And chest x-ray as well. And a lot of literature says that ECG and chest x-ray are standard in patients with dyspnea, and especially chronic dyspnea. Like, chronic dyspnea is always an indication for a chest x-ray. And then the other things really depends on the availability and the routines of the individual hospitals, but you can do an echo, which is great for cardiac, and echo can either be like on the chest or a transesophageal. And then in most, and then you have CTA, which is CT angiography, which tells you about the vessels of the heart and the lungs, and it gives you, it can give you information on whether you have an acute MI or pulmonary embolism and those kind of things, like vascular stenosis and such. And then you have spirometry and ECG with physical load tests. And as I said, like, it really depends on the availability. And then we'll go to the left side of the slide, and then you have a complete blood count. And I think it's just standard to do a complete blood count, and especially hemoglobin, because it can tell you if you have any anemia or anything. And these tests are very inexpensive to run. And same with CRP, white blood cells, and a standard ionogram, very cheap, very, like, it gives you a lot of information. And then you have creatinine and urea, which can tell you about which can be, like, these values can be altered in, for example, heart failure that has come a long way, liver tests as well, heart failure, BNP-NT-proBNP is brain natriuretic peptide. And do you know when BNP is good to run before I spill the tea? Jessica, you know this.
BMP. Does anyone know when we used it? Pro BMP, maybe?
Heart failure?
Yay! 10 points to Tim. And then you have cardiac troponin. Do you know that as well?
I guess myocardial infarction.
Yeah, cardiac infarction. And then you have ABG, which are arterial blood gases, and that is a great bedside test to run, and it can tell you if you have any acidosis, alkalosis, those kind of things, and then D-dimer. And what is the significance of using D-dimer in terms of predictive value? And if you don't know, then D-dimer is like a breakdown product of a thrombus. So do you know what the significance of it is?
You mean like when you would use it, or when it would be high?
What the value tells you, like whether it's high or low.
Like there's microclots or something.
Yeah.
Microthrombi or something.
So basically, like a D-dimer can be elevated in a number of situations, not only in a thrombotic event, but also, for example, post-operatively, it can be elevated in infections, but it has a good negative predictive value. So if you are suspecting a pulmonary embolism, for example, and your D-dimer is within reference range, then you can completely exclude PE, because if you have a PE, you would have elevated D-dimer. But a high D-dimer cannot confirm a PE, if you understand what I mean.
Again, please.
Okay, so basically a D-dimer has a negative predictive value. So this means that if you have a D-dimer that is within reference range, then you can completely exclude a pulmonary embolism or any other thrombotic event. But on the contrary, it does not have a positive predictive value, meaning that an elevated D-dimer does not diagnose a pulmonary embolism, because D-dimers can be elevated in a number of situations, such as infection and post-operative thrombotic events. But yeah, so it has a negative predictive value.
Okay.
Did you understand?
Yes.
Okay, perfect.
Thank you.
Okay. Cases. So
now, since we've covered all of dyspnea in 48 minutes and you guys know everything, we're going to go into some cases and see if you can diagnose any of these patients and see what they might potentially have.
Okay, so case number 1, you have a woman 48 years old, comes in with left-sided chest pain lasting 1 week with a recent feeling of breathlessness. Past medical history is unremarkable for cardiac and pulmonary disease, as well as thromboembolic disease. She had a hysterectomy 3 weeks ago, and that was uncomplicated, and she went home within a few days. Currently, she rates the pain a 4 out of 10. She does not report of any cough, fever, or syncope. Family history, her mother died from an MI at 78, but otherwise there's nothing significant in her family history. And she smokes a 10-pack per day.
10 packs per day?
No, a 10-pack per day. She does not smoke 10 packs per day. She smokes 10 cigarettes per day.
Okay.
She's not that heavy of a smoker. Yeah, okay. And then you do an examination of her vitals. She has an oxygen saturation of 95% on room air, respiratory frequency of 20, heart rate is 112 with regular action, which means that it is regular. Blood pressure is 118/90 on left side and 124/92 on right side. Always do it on both arms. Like, you should, according to books, do blood pressure on both arms, but like majority of people just do it on one. But like, if you want to be awkwardly correct, do both. And her temperature is 36.4. Then she has like the capillary refill time is less than 2 seconds. Physical exam shows no increased work of breathing, chest is clear to auscultation, heart sounds are normal, abdomen is soft with no tenderness on examination, and calves are soft and non-tender. And just like based on this, I do not want you to have miraculously diagnosed this lady like then and there, but I just want to hear what you are thinking and just why. This is just an open discussion, and no one is here to point any fingers and be like, no, you're incorrect.
Can I go on to the previous slide?
Yeah.
So is there anything?
So does it have to be related to the surgery or the operation? I mean.
Yeah, that is like a
good idea.
That's a good
Yeah.
idea.
I'd agree, like post-surgical something, maybe I'd take like D-dimers to check for that.
Okay.
Or any like thrombotics. ECG.
Yep.
For the heart.
Mm-hmm.
Is there anything else that jumps out at you from this from history? Maybe family history or so?
Maybe her mother died from MI, so maybe.
Okay. That's a very good.
Yes, already she has a family history of some kind of heart problems.
Is there anything you
I
feel
would
like
do like a CT angiography just to rule out the pulmonary embolism, maybe, since she has a bit of increased heart rate, and due to the operation and family history.
That's a very good.
Yeah, and recent surgery as well. That's great.
Yeah. Is there anything that you feel like you can exclude from just looking at kind of the patient presentation and examination?
I guess infection, like people have fever, for example.
Yeah.
Sorry, what again?
An infection.
Okay.
But also just mentioning kind of infection here. When you are immobile after a surgery, then kind of your mucociliary escalator is not working properly, and you don't have, because you have to be physically active to properly cough up and get rid of like things in your lungs, and that is a completely normal physiological thing. But once you're immobile, your mucociliary escalator doesn't work properly, so you see a higher incidence of pneumonia in immobilized patients after, for example, surgery. Just kind of remarking that is a very common question that's asked in the wards, in exams, like those kind of things.
Okay.
She smokes too, no?
Yeah, she smokes 10 per day, not 10 packs. But
10 per day.
10 cigarettes per day.
So with the smoking, what's that leaning you towards then?
COPD, maybe.
So, further examination, she has sinus tachycardia without ischemic changes or features of right heart strain. So the ECG tells you that she does not have an MI. Blood tests are unremarkable. Chest X-ray is unremarkable, and which is very common for what she had, like pulmonary embolism. But as Gunnar said, do a CT angiogram, and that showed a pulmonary embolism.
Also, with CT angiography, only doing if they are hemodynamically stable. So if someone is very unstable, you're not going to take them to CT.
And then now that Kornelia is mentioning the like stability of the patient, if this patient were hemodynamically unstable, but you have a strong suspicion of a pulmonary embolism. This was actually a case that I was given in intensive care. So is there any other imaging modality that you can use to diagnose a pulmonary embolism?
MRI?
You have to, like, you could because it's soft tissue, but MRI takes a good 20 to 30 minutes.
For example, like we're saying, she's unstable right now, and if we're not going to do anything very, very soon, she's going to die. So what is there any kind of like bedside modalities that we can do that could help us out?
Ultrasound, maybe, but I don't know if you could see anything there.
No, you're actually right. So basically, you can, to diagnose a pulmonary embolism indirectly, you can do, as you said, an ultrasound, like an echo of the heart. And if you have a pulmonary embolism, you will have increased workload of the right heart. So the echo would show kind of an enlargement of the right ventricle, as well as paradoxical movement of the septum. So when the heart contracts, the septum moves towards the left side, which is pathological. And it is indicative of higher pressure in the lung circulation. So you have indirectly diagnosed a pulmonary embolism. Case 2, this is a bit faster.
I have one more question. Can you go back one slide, please? If you say blood test unremarkable, does this include D-dimers?
Yeah.
So
or I don't know, because
okay.
Probably it was elevated.
Yeah, because if not, that would have like kind of made up the point with a negative predictive value.
Yeah.
That it's
No.
Yes.
I can send you the link to this case because I found this online in some journal, and I can send you the link to the case if you want to.
All right.
Case number 2, 19-year-old male presented with dyspnea, fever, myalgia, and generalized tiredness lasting for 7 days. He started with dyspnea on exertion a few weeks ago, and then he got worse 1 week ago. He is lucid and oriented, but appears pale and fatigued upon arrival to the ER. Past medical history is unremarkable. He's a previously healthy 19-year-old man. Family history is negative for cardiac, pulmonary, and metabolic diseases. He drinks occasionally, but he has never smoked. Pharmacological history, no regular medications or supplements. Vitalia are 99% on room air, respiratory frequency of 20, heart rate is 80, blood pressure normal, and he's subfebrile. He has 37.8. And then like physical exam is unremarkable. So what are your initial thoughts of this
Infection.
young man? Yeah. Mm-hmm. Anything else? Okay, so I assume that most of you are. Wait, we got a chat. So, oh, wait. Okay, so based on this information, like I assume most of you are thinking about a infection, but then. What if I tell you that he has been vegetarian for 1 year? Does that change your list of differentials?
Oof.
Could be like anemia then, maybe.
10 points. Because like, if you go back into the history, you see that it started with dyspnea on exertion a few weeks ago. So basically, he has gradually become anemic, which was the case here.
And also, the fact that, I mean, if we're going to look at general appearance as well, they did say that he was pale when he came in. Okay, that's probably not like the best thing, but if we're now thinking about it deeper into the history, for example, like pale skin is also, or pale conjunctiva and stuff like that could also show anemia.
So basically, in his case, the labs showed a hemoglobin of 6.6, and in men it should be from 12 to 15 approximately grams per liter, and he had low B12 with negative antiparietal antibodies. So basically it was he did not have autoimmune pernocytic anemia. It was due to low intake. And then his final diagnosis was pancytopenia due to low intake of B12 with a resulting esophageal candidiasis, which is explaining the symptoms of infection. Do you have any questions?
No.
Okay, so we have a 58-year-old man who states that he has experienced mild dyspnea on exertion for a few years now, but more recently he has noted worsening shortness of breath with minimum exercise, and the onset of dyspnea is at rest, with minimum exercise and at rest. So he has smoked about 2 packs of cigarettes per day since the age of 15. On physical examination and the vital signs, we see a blood pressure of 130/85, the heart rate of 96, respiratory rate of 28 breaths per minute. And he's using his accessory muscles for the respiration. So the chest examination reveals bilateral wheezing, and the anterior posterior diameter of the chest wall appears increased. So anything that jumps out at you straight away?
COPD.
COPD.
Yes.
Okay, that's great, but why are we thinking that?
Because of the barrel chest, perhaps, emphysema maybe. And
Okay.
also, I mean, 2 packs of cigarettes per day, most likely fibrosis has damaged the elasticity.
Also, it must have been something like progressive when it was like on exertion for a few years, and now it's becoming like more acute.
Exactly.
That's
something I wanted to. Yeah, that's a really good point, because like we were saying before, with COPD it's more chronic, and he's saying he used to first have dyspnea on exertion, but now he's even noting it during rest. So that should already point to us that it's not something that just happened overnight. It's not acute. It's chronic. So that's why we suspect COPD. So is there any test that you would do next? Is there anything else that you'd want to know about him?
So
I would do a pulmonary function test like spirometry and forced
Yes.
expiratory. Yeah.
The ratio. What's it called?
FEV1 over FEV2.
FFV. Yes.
Also, like SpO2, maybe.
Yeah. And any labs that we could focus on?
Like blood gas.
Yeah, exactly. So we want to do an ABG as well, because the problem is that he's got a very high respiratory rate, and we don't want him to go into some kind of respiratory acidosis, which we'd have to fix.
But what about any imaging? Would you want to do any imaging of this guy?
Chest X-ray.
Bingo. Should I press next slide?
Yes. Okay, so perfect. So we have, okay, we're going to go as quickly through this as possible because we're a little bit running out of time. So we have a 63-year-old patient that presents with a history of coughing and wheezing for the past 5 days, and a shortness of breath that has got worse over the past 24 hours. So it first started with a dry cough, with a thick rust-colored mucus, and then she noticed some wheezing after the coughing spells with a sharp pain in her chest, and she also has a temperature of 37.8 degrees. So she has a history of hypertension, and she's been a smoker for 30 years. So her vitals show that she has 110/80, heart rate 96, respiratory rate 26, and the saturation is 94%. So on physical examination, she appears fatigued, and she has a congested cough, and also she has wheezing in the right lower chest with expiration. So what's the most likely differential diagnosis? And why would you say that? if, for example, we're thinking about the onset, how long has she been having it?
Asthma.
Respiratory tract infection
Okay, so why do we think that?
is due to the time. It's just been the past 5 days. She has a bit of elevated temperature.
Yeah,
And also the color of the mucus.
exactly.
Mhm.
So like we were saying before, we're not only just talking about like her dyspnea, we're also thinking about is there any accompanying cough, and then we're then thinking about the color of the cough, the sputum as well that's coming out. So if we think it's some kind of infection, what imaging would help us to differentiate if it is an infection or not?
X-ray.
Yeah, so chest X-ray. For example, if this woman had pneumonia, and with an X-ray, it would show, for example, what type it is. If it's a lobar pneumonia, which would be very well seen on an X-ray. Okay, so next, do you want to go next?
So now, I don't want any diagnosis, but this is just to kind of further stimulate this train of thought and just like throw out whatever you're thinking of and why you're thinking of it, if you have any idea. So number one, 28-year-old female with chest pain and hyperventilation. She has normal vitalia, no exertional dyspnea, and no cardiac and pulmonary risk factors. She takes no regular medications beside combined oral contraceptives, which she has been taking since she was 22. What are you thinking in this case?
Pulmonary embolism?
Yes. Yeah. Anything else that you could think of in this lady?
Well, I thought for a second maybe something to do with diabetic ketoacidosis because of hyperventilation, but there's nothing mentioned about anything there, so potentially not.
Yeah, but like it's something good to
Also,
keep in
like
mind.
pretty young female, like I don't want to generalize females, but like anxiety or like something psychological maybe.
Yeah, no. Like it's not a generalization. It's just pure facts. It is more prevalent in females, but also on Cameron's remark of like diabetic ketoacidosis. For example, if she had a history of diabetes, for example, type 1, then you would maybe think of doing an arterial blood gas just to exclude that as a potential cause of the dyspnea. Anything else? So this is what I just wrote down, but of course there are a gazillion things ways to go about it. Wow, no. Spoiled it. Okay.
We didn't see it, don't worry.
Okay.
Okay, so we have a 65-year-old male with progressive dyspnea and bilateral pitting edema of the ankles. He's been treated for hypertension since he was 53 years old, and his mother has died from an MI at 71.
Heart failure.
Heart failure,
Heart failure.
something that's the heart failure, or again, pulmonary embolism, maybe.
Yep.
Heart failure, pulmonary embolism.
It's a safe bet, always pulmonary embolism.
Yeah.
Any other diseases that we can think of?
Like, okay, so when you're reading, just kind of to reflect over what you're thinking, why are you thinking cardiac failure in this patient? What are kind of the factors that are leading you towards cardiac failure?
Leading
Edema.
edema.
Bilateral edema.
And also, I
Plus progressive dyspnea.
Yeah. And
What about the edema?
Yeah, it's edema.
Well done, I'm sorry.
I
Ignoring
didn't hear, my sound just went out for a few seconds, but also the fact
Okay, so
that he was treated for hypertension. Well,
yeah, treated for hypertension and the whole pitting edema. I would also suspect, for example, maybe cirrhosis.
Yeah.
Maybe some kind of kidney diseases as well.
Yeah.
So yeah, you basically mentioned it: cardiac failure, ischemic heart disease, pulmonary embolism, and So basically, male dyspnea and pitting edema should make your minds go toward cardiac failure, and he should not wait for an echo. He is eligible for an immediate echo. He should not wait until the next day. This is the last slide, so then you're off.
Yep.
75-year-old male comes to his GP complaining of 6 months of breathlessness. He has had a productive cough most days, but recently it has worsened. He has smoking history of 20 cigarettes per day for 30 years. Auscultation of the lungs reveal widespread wheezing. What do you think initially?
COPD, some
PD, yeah.
obstructive disorder.
Mm-hmm.
I think that's related to wheezing.
Yeah. Anything else?
I mean, could also be maybe something infectious with a productive cough.
Yep. That's a very good point. Anything else, considering that he's so old and he has been smoking for 30 years?
Some type of tumor or cancer potentially that could slowly start manifesting symptoms, but so get like a chest X-ray or something and see this development.
Yep. That's a very great point. Anything else? So yeah, as you said, COPD, pneumonia, bronchitis, and malignancy. And what if this patient was 25 years old and with a negative smoking history? What would if someone presented with progressive dyspnea, like productive cough and wheezing, but he was 25 years old and had no smoking history, what would you think of then?
Asthma.
Yes.
Yeah.
You don't need this lecture.
Yeah.
What are we doing? Okay, so last one.
Okay, so mother comes into the ER with her 6-month-old daughter who shows increased respiratory effort and the use of accessory muscles. Also with fever, and the mother describes her to be drowsy. So 3 weeks ago she had a cold, which she recovered from. So based on the age and what the mother has described, what are we thinking?
I don't remember the name, but I remember from Sketchy this little baby virus with the ghosts.
Yeah.
Pneumocystis something? No, no, that's not, no.
No, you're remembering the right Sketchy.
Yeah, but I don't know what name that
Is
was.
it like it's the seal? This like no, it's like the something the seal on the walls. No, croup something like that or
Yeah,
No, it's-
that is
Yeah.
also a very legitimate differential in this case.
Yeah, croup is really exactly.
I mean, we wouldn't tell the patient that we saw a picture of like a seal on the wall, but yeah, croup.
Tell the mother. Anything else that in like a small child with dyspnea that you would just be aware of? Not only think about this case, but small children with dyspnea.
Heart defect, maybe.
Pneumonia.
Mhm.
Some type of like infection, like either viral bacterial with drowsiness, perhaps. So I feel like that's a key to something, but I don't know what it unlocks.
What about children? You know, they're all over the place. They're trying to put things in their mouth and stuff like that. What could possibly happen?
Something obstructive, something they swallowed.
But this
Yeah,
one
so
lasts for
something
3
like
weeks.
airway obstruction. Yeah.
This will last for 3 weeks, though.
No. We're just talking generally about younger children. I don't know. This is just generally if we're talking about younger children as well.
But yes, the first one on the list is bronchiolitis from RS virus, like croup, and then you have pneumonia. Why did I write croup 2 times? And then also epiglottitis, but epiglottitis is not very common these days because of vaccination. But of course, like especially immigrants who are non-vaccinated, you should be aware of the potential for epiglottitis, and that is a medical emergency.
Yeah, it's a medical emergency.
So yes, thank you for attending and participating like you did. That was very good, and I had